From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Hello, everybody. Welcome to a JAMA Cardiology podcast. My name is James Udelson. I'm Chief of Cardiology at Tufts Medical Center in Boston and an Associate Editor at JAMA Cardiology. Today, I'm joined for our podcast by Divaka Perera, who's Professor of Cardiology at the School of Cardiovascular Medicine and Sciences at King's College in London, and also by Julio Panza, who's Director of the Department of Cardiology at Westchester Medical Center and Professor of Medicine at New York Medical College in Valhalla, New York. Divaka, welcome.
Hi, Jim, and thank you for inviting me to this.
And Julio, welcome to you as well.
Hello, Jim, and again, thank you for this invitation.
So let me start. We have in JAMA Cardiology a paper coming out by Divaka, which is the Viability sub-study of the revived BCIS-2 trial that was initially presented last year at the ESC and published in New England Journal late last year in 2022. Divaka, can you tell us in general about the parent trial, revived BCIS-2, why you did it, and how was it done? What were the results?
Sure. So the aim of Revived BCIS-2 was to try and answer a question that we faced routinely as clinicians. Should we revascularize patients who have severe coronary artery disease and extensive left ventricular dysfunction with a view to improving their LV function and thereby giving them some mortality benefit, some survival benefit, as well as an improvement in quality of life? This is something that's been done for decades, but hadn't really been assessed in a randomized controlled trial using PCI as the means of treatment. Of course, we had the STITCH trial, which addressed this sort of question, but with surgery. So in Revived, 700 patients were randomized to have optimal medical therapy alone or optimal medical therapy plus PCI, and PCI was performed to try and treat all of the coronary disease that subtended viable myocardium. And to enter this trial, in addition to having extensive coronary disease and impaired left ventricular function, you needed to have some expectation that the left ventricle would improve. So you needed to have 4 segments that were dysfunctional at rest and shown to be viable on whatever modality of testing that you used. And that's really pertinent to the study that we're going to talk about in more detail today. And follow-up was continued for a minimum of 2 years. And by the end of the trial, we had about 3.5 years of follow-up, a median follow-up. The primary outcome was death or hospitalization due to heart failure, and there were a whole host of secondary outcomes, mechanistic and quality of life outcomes. And what came as a surprise to many when we presented it at ESC last year was that there was absolutely no difference in death or heart failure hospitalization in the two groups, whether treated by OMT alone or by PCI as well as OMT. And those curves were essentially superimposed throughout the entirety of follow-up.
That's great. And also of real interest, there was no difference in the change in ejection fraction over time. It was quite interesting compared to what we might have expected from all the observational data.
Yeah, exactly that. So there was an improvement in ejection fraction of a median of about 5% absolute change in EF at 6 months. But that was the same, regardless of whether you were randomized to medical therapy or PCI.
Now, given that, tell us about the JAMA Cardiology work.
So really, one of the main aims of this pre-specified sub-study was to find out whether there was a population in whom PCI would give us benefit. Again, mirroring what we do in clinical practice. We use viability tests to try and pick patients for revascularization. So all patients in Revived had a viability test. In the majority, that was cardiac MRI. 70% or so had cardiac MRI, and in the remainder, most of the testing was by dobutamine stress echo. There was a handful of patients who had nuclear medicine tests. It's not a common test to be done in the UK, so we actually excluded those patients. We couldn't generalize that information. So viability testing by stress echocardiography or MRI meant that you were eligible for this sub-study. And just over 600 patients met these criteria, in whom we could get all of the information we needed, not only viability tests, but actually paired left ventricular function data by echocardiography. Now, all of these imaging modalities were reassessed and reanalyzed by core labs for cardiac MRI, dobutamine stress echocardiography, and the serial LV function in an echocardiography core lab. And those echo core labs were blinded not only to treatment assignment, but to the temporal sequence. So they didn't know whether they were looking at a 12-month baseline or 6-month echo. We wanted that to be truly blinded. And question one was, does the extent of viability influence the outcome following PCI? Is there a difference in patients who have lots of viability? And an important thing to understand when reading this paper is what the definitions of viability mean. And there's a bit of confusion even in clinical practice. So we divided the ventricle into 3 types of myocardium. Firstly, we stratified it by baseline wall motion. And if your baseline wall motion was normal, that was classified a normal segment. If it was dysfunctional at rest, at baseline, then they were subdivided into those that had an expectation of recovery or there was no expectation of recovery. So they were called viable and non-viable. And the expectation of recovery depended on your modality. So with cardiac MRI, we used a late gadolinium enhancement transmurality threshold, less than 25%, great expectation of recovery, greater than 25%, lesser expectation of recovery. And with the bitumen stress echo, it was contractile reserve. Having classified the ventricle according to these 3 types of myocardium, we then looked at the outcomes. All of the outcomes in the trial, we looked at it by the amount of that particular type of tissue, viable or non-viable tissue. What was really striking was that there seemed to be no difference in the outcome, whether you look at death or heart failure hospitalization, the primary outcome of the main trial, death alone, heart failure hospitalization alone, at all, whether you were assigned to PCI or medical therapy, when you stratified these patients by those viability characteristics. And for me, what was even more surprising was left ventricular function, the improvement in LV function. Even that wasn't different. And that's really where our whole hypothesis of hibernation came from. So, that was the primary result. How does our viability characterization affect the outcomes with revascularization? Our second and really important set of outcomes was, if you put the treatment assignment aside, how do these characteristics predict outcomes in the population as a whole? And when we did that, we were really comparing the extent of viable myocardium, non-viable myocardium, and in the cohort who had CMR, cardiac MRI, the scar burden. And this was the second surprise. The extent of hibernating myocardium didn't seem to be predictive of any of the major prognostic outcomes at all. And, that might be taken to be hibernating myocardium. We didn't directly assess hibernating myocardium, but our definition roughly corresponds to hibernating myocardium. On the other hand, when you looked at non-viable myocardium by either modality or the amount of scar by cardiac MRI, that was very predictive of outcomes. So it seemed to be that what's expected to recover was less important than the damage that has already happened.
It was so interesting, and that's why we were so interested, in the paper. I mean, there are a lot of implications. Let me turn to Julio, who wrote a very thoughtful accompanying editorial. And Julio, can you summarize your thoughts about the paper and the data and what you saw as the implications?
Yes, thank you. So, first of all, I think I need to congratulate the Revive BICIS investigators for what I think is an extremely important trial. And I think it's extremely important because the objective of this trial was in everyone's mind prior to starting the trial. So I think that to me is the epitome of what makes a trial relevant, is whether the question being asked in the trial is a question that is being asked in the clinical arena, which in this case it is. And that I think was even more true after the publication of the STITCH trial, because the STITCH trial, as we know, was performed with revascularization against optimum medical therapy alone. And then everyone asked, okay, can we do the same or can we obtain the same results with PCI, which of course is more attractive in patients with LV dysfunction because you avoid the initial risk of the operation. And then obviously the viability sub-study was also in everyone's mind, is the problem with the so-called negative results of the STITCH related to the fact that it was surgical revascularization. So to reiterate, a critically important study, I think we need to point out 2 major differences between STITCH and Revive BICIS. One obviously is the mode of revascularization. And this, I think, goes beyond the difference in the initial risk between the 2 procedures. And I think it impacts on what is the goal of doing revascularization with either surgery or PCI. And I think we need to talk about this in greater detail later. And then the other difference that may explain some of the results in the viability sub-study is Divaka said the revived business study included only patients with a certain amount of viability, whereas the STITCH trial and the sub-study included patients that had no viability when, again, assessing viability in a binary fashion. So obviously the question is, what do we do now? We have the STITCH trial, the viability sub-study, in the context of a trial that showed an improved prognosis with revascularization overall. The sub-study showed that there is no interaction between the treatment effect of CABG and the presence or absence of significant amount of viability. And those negative results were echoed by the sub-study of the trial of revived business. So what do we do now, and to what extent is viability important, if it is important at all? And I think that is what I tried to emphasize on my editorial comment, that I think that there is still some role for viability assessment in a sort of individualized fashion, in a more qualitative fashion, than simply dividing patients into with or without viable myocardium in a binary fashion.
Well, Julio, can just follow up on that last point. Can you give us and our listeners an example of a patient where the viability information would still be helpful and drive you in one direction or another regarding a decision?
Yeah, I think that the viability information is always important. I think we need to make a distinction between the assessment of viability with whatever method versus doing a dedicated study, MRI, dobutamine echo, or nuclear study, to assess viability. And I think that we always think of viability when we see a patient. Obviously, I think that there's no patient that will be considered for revascularization without an echocardiogram, for example. So let's say that we're considering a patient with a critical lesion in the proximal LAD that has dysfunctional myocardium in the territory subtended by the anterior septum, the apex. And we do an echocardiogram and we see that the thickness is preserved and the segments are hypokinetic as opposed to akinetic or dyskinetic. Well, I'm not sure that we need to do an MRI or any other study, and let's say that there are very little or no Q waves on the EKG. Well, we are making an assessment of viability without a dedicated study. And I would submit that that patient, depending on the disease of the other vessels, depending on the status of the patient overall, age, kidney function, all the things that should participate in the decision-making process, I would think that that patient, in principle, needs to be revascularized there, right? So I think that that is a very important thing to consider. Are we talking about viability overall, or are we talking about a dedicated and sometimes expensive test to assess for viability, in addition to the more generic test? Let me stop there and then to address the issue of recovery of left ventricular function.
Okay, and back to Divaka. So given all of the data from STITCH and now your trial, what do you see as a clinical situation where this type of testing might still be useful and discriminatory for making a decision?
So I think viability tests still have a really important role, but perhaps not in the way that we had used it before. For instance, I tend to, and especially after the results that we've seen from our own data, tend to have cardiac MRI quite high up the pathway in assessing these patients. Firstly, to establish etiology and to separate non-ischemics from ischemics. A question I've been asked frequently after Revive was published is, do we need to even know an angiogram? Because if you're now telling us that revascularization is a benefit, why would we need to know? Because there are very, very important differences in how we treat ischemic and non-ischemic cardiomyopathics, not least giving them statins and aspirin and so on, but also in how we stratify their risk for ventricular arrhythmias and select patients for ICD therapy. So I think that's useful to do and to give us an overall impression of the prognosis of the patient as a whole. I don't personally find that the viability test should or would drive us to consider revascularization in a patient who otherwise didn't meet criteria for revascularization. So if they had angina or significant symptoms that we couldn't be certain were not ischemic and due to inducible ischemia, then you would consider revascularization anyway, regardless of the viability test. And the example that Julio gave, which was a proximal LAD lesion or let's say a left mainstem lesion, I don't know that a viability test in those sorts of situations would ever put you off revascularization if all of the other metrics drove you to revascularization. So I don't think it's useful to tell us who not to revascularize or who to revascularize, but having that information allows us to manage the patient overall.
And Julio, you mentioned the issue of recovery of LV function, in STITCH and in Revive BCIS2, the big picture outcomes, cardiovascular death, heart failure hospitalizations were all neutral. The LV function data wasn't that different either. Is that still a useful target and something you are targeting in thinking about doing these tests?
Yeah, so I think we're getting close to what I think is the crux of the matter here, which is the fact that recovery of revascularization has been sort of the gold standard for viability and has been central to everything that we have expected when we think of viability and revascularization. So first of all, the concept of viability was born out of the description of recovery of left ventricular function. Second, all the tests that we currently use for viability assessment used recovery of function after revascularization as the gold standard. I think I mentioned briefly in my editorial that that implies, for example, that if a segment did not recover after revascularization, and most of the studies validating this test were done with surgery as the method of revascularization, then that was considered that the segment was not viable. So therefore, if the test did show viability, that was considered a false positive. Well, we can think, for example, of someone having a perioperative myocardial infarction or even preoperative myocardial infarction between when the test was performed and the surgery to think about the explanation for the discrepancy. And then finally, the concept that we should revascularize these patients to prevent heart failure, and which of course goes hand in hand with the recovery of left ventricular function. I think that both STITCH and Revive BICIS show that the recovery of left ventricular function is related to viability, but not to the treatment. So the left ventricular function improves, and we showed that in STITCH with both surgery and the optimization of medical treatment. And in Revive BICIS and the viability sub-study, left ventricular function improved, Divaka said, by about 5% in EF, but no difference between PCI and medical. So viability determines recovery of left ventricular function, but not necessarily due to revascularization.
Very important distinction there.
Very important. But then I think the even more important issue is that I say, okay, I'm going to do revascularization, regardless of the method, to improve left ventricular function, because that will lead to improvement in heart failure, reduce hospitalizations, reduce in deaths due to heart failure. That's great. I mean, I think that that is a great goal, and that is probably where the viability in a dichotomous assessment may be important. The issue is that in someone, let's say with 25% EF, who's walking as opposed to underground, must have viability. And we need to protect those segments. So if we expect recovery of left ventricular function as the goal to be attained, and then we say, okay, if left ventricular function doesn't improve, we fail, I think is an erroneous assumption. I think that what we need to say is this patient, whether the left ventricular function improves or not, we need to protect what is viable. Obviously, we will not protect if there is no significant stenosis, obviously. So if there is viable myocardium that is subtended by a critical lesion, we need to protect that viable myocardium. And that is where I think the importance of the viability test, with or without a dedicated test, the viability assessment is important. Because obviously, we wouldn't try to revascularize a segment that is completely dead, which, by the way, this goes hand in hand with Divaka's observation about the importance of the lack of viability, meaning the scar, as a prognostic piece of information.
Well, that's great. One final quick question, Divaka, is do you think that the differences between what both of you have shown in your papers and the older observational literature says something about contemporary medical therapy and how excellent it is?
I think it does, because even between Stitch and Revived, Julio, there's been a real revolution, or evolution, I should say, in medical therapy. So that makes even those two trials, which are relatively close to each other, difficult to compare. But when we go back in time to the earlier literature, that the medical therapy as we knew it then bears virtually no resemblance to what we do, the 4 pillars of heart failure therapy. And in that context, there seems to be more than one way to help your patients to have left ventricular recovery. And I wonder whether the whole concept of hibernation needs to be reframed, not towards ventricles that recover because you revascularize them, but ventricles that recover for whatever reason, medical therapy plus or minus revascularization.
That's great. Well, thank you both very much for a really interesting discussion. And for our listeners, please look at the paper and the editorial. Really, really excellent, which is why we took them both. My name is Jim Udelson. I've been speaking with Divaka Perera and Julio Panza about their paper and editorial in JAMA Cardiology. You can find a link to the paper in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you happen to get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks so much for listening.